Right, good morning and welcome to the Health and Adult Social Care Scrutiny panel. Just in terms of the agenda, unfortunately we have apologies from Councillor Liz Smage, who is obviously the chair of the panel. Before we start the meeting, we'll obviously need to elect a chair for the meeting. So do we have any nominations, please?
I'd like to nominate Councillor Nell Griffin.
Okay, is that seconded?
I'll second that.
All in favour? Okay, so Councillor Griffiths, if you'd like to come to the top table, please.
Good morning and welcome to the panel. I'll ask you to be kind because this is my first time. Do we have any apologies for absence?
Obviously, Councillor Smage, and we've also had an apology from Lynn Keedy, one of our co-optees.
Thank you. So first, we'll take the minutes of the previous meeting. Are there any comments on that? Would someone like to propose them as a true record? Yeah, Peter and Fazila. Thank you. If you have any disclosable interests, can I ask the panel to let us know now? Okay, this is an open public meeting. And we have a deputation from Jeff Fox. So I'll ask you, Jeff, to give us 5 minutes. Thanks. You need to press the large button.
Okay. Yes, so my name's Jeff Fox. I'm the father of a child who suffers from FASD. She doesn't have any facial features. Her mother had a history of drinking alcohol during pregnancy. She's adopted. The reason why I ended up writing to yourselves is because I wrote to the CCGs for Kirklees and whatever it is, North Huddersfield, and after I got different responses from both. The first response I got was, we don't have no records at all of any children with FAS or FASD in the area. The second response was from the other CCG, which said we'd had 4, I think, in the last 4 or 5 years. Now, I'm a member of a group of people in West Yorkshire, and there's at least 70, 80, 90 people in that group who are also aware of other people who have definitely been diagnosed. There's also many, many others who are suspected that they have a diagnosis, that they should have a diagnosis. But within the CCGs for Kirklees and North Huddersfield, there is no pathway to get the diagnosis. Kate Ward, who's just joined, was the only person pretty much in the entire area, and she worked at Airedale Hospital, who could do a diagnosis. She's retired, and there is nothing to replace it. So there's no diagnostic pathways. If you do manage to get a diagnosis, then there's no support for the diagnosis. I mean, CAMS will look at ADHD. ADHD can be a part of FASD, but it's only a part of, and they will not look at children with FASD until you get an ADHD diagnosis. So it's just a mess. There is no umbrella that joins it all up. Just looking at my notes, sorry. So yeah, it's difficult to get support services. There's no diagnostic pathway. There is no support for adults who've been diagnosed once they reach 18. There is nothing out there to look out for those young adults. Do you want to say something, Claire?
I'm Mrs. Fox, Claire Fox, Jeff's wife. I think one of the other very, very difficult things for the parents of a child with
Got 30 seconds.
So I think our proposal, which comes under the solutions part, is that there is a pathway needed for children with FASD. Most recently, there's been a report into government that says there's around about 17% of children with FASD in this country. It's much wider than just FAS. I know there are studies that are looking at that very small area, which is equally important, but it is much smaller than just FASD.
That is now the end of your 5 minutes. We would like to invite you to stay on anyway in the meeting, and we'll be very interested to get any further information from you as time goes on. Could you press your button? Yeah. So, do we now have a deputation?
Kate, wishing to say a few words?
Yes, I think that's...
Well, if you can...
I'm used to shouting. I think there's three issues, really. I'll try and be brief. But there are three main issues that I think are very important. It is a very complex condition, and these children do not fit neatly into diagnostic categories such as learning disability, ASD or ADHD. And people will often try and lever them into one of these conditions, and when they don't quite reach the threshold, then they don't have the condition, and then you fall out of the system. So the first thing I think is very important is to say that fetal alcohol syndrome is different in a sense to FASD. Fetal alcohol syndrome, where the children have characteristic faces and they're little, are the tip of the iceberg. But there's a very much larger group of children out there with the developmental and learning and behavioural and social difficulties who are problematic and who need special support in schools. That's number one. Number two is that they're a very diverse group. Some of these children will present with profound learning difficulties. Others are actually very bright, but will have a spiky profile whereby they may have significant difficulties with memory, with auditory perception, but actually are very bright. But they may have difficulties with social interaction. A lot of them do reach the threshold for a diagnosis of ADHD, but they're not all the same. You can't say this is a typical child with FASD because they're a spectrum, and in a sense they all need their own tailored plan within school. I would say the third thing, and this is very important, is that it's very important to avoid the blame scenario, which you've heard a bit about. But a lot of these kids have comorbidities. A significant number, but not all, will have been in the looked after system or adopted, so they will have had the additional problems of neglect, of early trauma and stress, abuse, and inconsistency in their education because they've been in the looked after system. In my group of kids, I found about 10% also had chromosomal abnormalities, and that has been observed by other people as well. So they are a complex group. But I think it's very important. It's difficult to say this is the pathway which you need for FASD. The plea would be that we don't write these children off as being lazy, naughty, or the subject of inadequate parenting. I think it's important that they are seen as a group with significant need, and if they are given the right support, they can achieve wonderful things. I have twins that I've seen not in this area, who are both beyond grade 8 and at foundation teaching level for 3 instruments, and one of the girls achieved a place at the conservatoire, but only actually as a result of home tuition because the education system could not support her. Without support, a significant number of these kids do very badly. They end up in prison, they end up with severe mental health problems. So I think we do owe it to these children to see them as they don't fit into ASD, ADHD. Levering them into that system will leave them neglected in terms of their other needs, which are significantly high. There isn't a simple answer, but there are some models in the country, and I think if you don't start thinking about them as a group, you know, we were in this situation when I came to Airedale 30 odd years ago. We were in this situation with autism. It was a bizarre condition that I wasn't allowed to diagnose because there wasn't the need, and I think we're kind of at that situation now with FAS.
Thank you, Kate. At this stage, do any members of the panel want to ask any questions of our deputies? Okay. So now we have Catherine Johnson, is that right? Yeah.
It is.
Yep. Can I ask Catherine Johnson, consultant neonatologist and researcher? Thank you.
Hi, thanks Kate and thanks Mr and Mrs Fox. I feel a bit of a fraud against a paediatrician with 30 years experience and FASD parents, but I just sort of paint a picture of where perhaps I'm at and how I've got involved in this. So I'm the lead for a national study looking at the incidence in the UK and Ireland of fetal alcohol syndrome. So as Mrs Fox has said, this is the absolute tip of the iceberg. This is the tiny point of the iceberg of the top of the bit that's above the sea. So it's a very, very small proportion, and that has to be noted. But it's something that they've wanted to do in the UK for a long, long time. It's taken a long time to get off the ground. And whilst it won't represent children with FASD, it will give us a starting point in terms of research in this area. The reason we can do an incidence study of FAS is because there are very clear, agreed diagnostic criteria for FAS. Whereas with FASD, as Kate and Mr Fox have said, it's a much more complex condition. So you can't say this child has A, B and C, therefore they have FASD, whereas you can with FAS with the clear criteria. So we're starting simply with a study of the incidence in the UK of FAS, and just as a slight background, how that works is all the paediatricians in the UK receive a card, or electronic card it is now. It used to be an orange card that appeared on your desk. Yeah, in the olden days it was an orange card, now it comes via email. And it has a selection of rare conditions on it, and you tick a box if you've seen a child in the previous month with FAS, and then you get sent a questionnaire to give some more details about that child and the services they're using and what they're facing and what their abnormalities are. So that's how that works, and that's going to go on for a year, and that'll be till November 2019. So that's ongoing, and that's very much just about FAS. Now what we'd love to do, absolutely love to do, is to do the same thing for FASD. So FAS is probably classed as a rare disease. It's not common, the sort of full-blown fetal alcohol syndrome. So what we'd like to do is do the same thing for FASD, but accepting that there's no agreed diagnostic criteria in the UK or in the regions. You can't send a note to paediatricians saying, have you seen a case of this, if we can't tell them what a case of that is. So some of the things I'm trying to drive forward separate to the FAS study is to look at trying to get, accepting it's complex, a better diagnostic pathway in the region. Now, I'd set up a meeting, and I'm just thinking about it, we had representation from a community paediatrician in Bradford, in Harrogate, in Leeds, not from Kirklees actually, so that might be something we can, rather than reinventing the wheel, could a paediatrician from Kirklees come and join us, and we can work together, and looking at your first solution, looking at a regional West Yorkshire pathway, and if we can get a diagnostic pathway, that'll lead to us being able to truly do an incidence study of FASD. It will also be better for the children because we'll have a system. I don't think we need to completely reinvent the wheel. I think there's good Canadian and Australian FASD diagnostic pathway, which has actually very recently been mirrored by Scotland, and their guidance on the diagnosis of FASD is finished, but they're not quite ready to share it with me. I'm on a weekly email at the moment to them, and I think they'll give in soon. So I don't think we need to reinvent the wheel. I think we need to look at that guidance and then perhaps try and apply it to our region and any nuances of the region. And the other thing we've talked about in our meeting in terms of getting better FASD diagnosis is accepting the constraints we're all under in the NHS and public health, and using the resources we've got wisely rather than necessarily needing a lot of extra money to try and get this right. And certainly the mirrors with the autism pathway 30 years ago is certainly something that's been repeated.
Well, I think we need to look at developmental assessments as a whole and maybe not rejig the whole lot, but in fact, rather than, you know, if you get this and they go...
Sorry, Kate. Yeah.
They go through autism and they get kicked out, then they go straight...
Could we have I'll set aside a few minutes for discussion towards the end of the meeting. If we can just take the presentations. Yeah, thanks.
So that's kind of me and where we're at and what we're trying to do, which certainly needs to be extended out to Kirklees, I think, in terms of... Because I think the worry is with such conditions that you've got lots of people doing little things, and actually we need to sort of pull together and do it all together.
Thanks very much, Catherine. What I'm proposing is that we hear from our other officers, and then that the panel ask questions. Is that right? Okay. Yeah, right. So, Tom Brailsford works jointly with Kirklees and the NHS.
Yeah, thank you. I mean, obviously I've provided a report as part of this which outlines our current position really, and I think it's clearly more in relation to FAS rather than FASD when you look at our provision. And I think, like most areas, we're trying to deal with the signs and symptoms of FAS or FASD within the current resource provision. So, for example, I'd be very interested actually, was it Kirklees CAMS where you've had problems? Yeah, I'd be interested to pick up the individual detail of that outside this meeting, because I actually commissioned the CAMS pathway. But what I've been told, because as part of doing the report, I've contacted people, and CAMS are saying that they would deal with any of the signs and symptoms of FAS through either the Learning Disability Service or through the mainstream CAMS provision. So I'd be really interested to pick that up. The paediatricians say that they do screen, and that's outlined in the report, and where appropriate they refer on. The particular paediatricians are Gillian Parry, Calderdale and Huddersfield Foundation Trust, and Dr Singh at Mid Yorks Foundation Trust have given that information. So again, maybe we need to explore further how that actually relates to FASD rather than FAS. We have quite a well-developed service that sits within our substance misuse provision, which is to work with children of substance misusing parents, and that's been around for quite a while. But that primarily focuses upon the kind of, not the behavioural side of things, but maybe the emotional issues that are being explored as part of being a parent, a child of a substance misusing parent. We also have educational provision in Kirklees. I'm sure you're aware, Mandy will say a bit about it, that actually it's not reliant on a diagnosis to access services. So actually it's about the behaviours children and young people are exhibiting to whether they can get specialist support. So Mandy will pick up on that a bit further. And part of the other issue is the closeness of FASD to ASD and ADHD. Now locally we're pretty good in the region. Most areas have lengthy waiting times for autism. We've brought ours down to just about 10 months, and in the next year we'll be bringing them down to about 6 months. And as part of that, we've got a combined neurodevelopmental pathway which picks up kind of signs and symptoms of ADHD and ASD, and I suspect a lot of children who are experiencing AFSD will end up coming under that umbrella. So there's an opportunity there, because we're just doing this new neurodevelopmental pathway. Excuse me. So I think in summary, we've got services that identify FAS. We've got services that will deal with the signs and symptoms and behaviours, but we haven't got what you'd call a discrete provision for FAS or FASD. And we've obviously, there's a prevention side of things as well. So Emily Parry-Harris couldn't be here today from Public Health, but part of the prevention agenda as well. So there's the two things, isn't there? There's the children and parents experiencing, but also the prevention side of things, and that message is very clearly going out about zero alcohol during pregnancy through our school nurse and health visiting service. And we also do have some specialist provision in the south, which I think is outlined in the report, called SWANS, which is a midwifery service that works with pregnant women who've got a range of vulnerabilities, really, whether that's alcohol use, substance misuse. So we've got the bones of a structure to be able to do something about that. And I think in terms of your recommendations, certainly the awareness raising and the training aspect of things is quite worrying if you've had experiences where paediatricians don't know anything about that. And I think the other aspect we have is we clearly don't know enough information. So when I asked Public Health to tell me what they knew, all we could judge it on was hospital admissions, and that's where the 5 or 4 children comes from over a year's period, because it's actually just based on hospital admission data. So we really need to link in with the work that you're doing to be able to really understand what the need is locally and how we can better support that need. Is that okay?
Thank you. So now, Mandy Cameron, Head of Service for Education, Safeguarding and Inclusion. Tell us about what you can do there.
Okay then. I have very little to add to the information that Tom's given you, actually. I'm here because Tom and I work incredibly closely together. And so I felt it was important to come at it from the education perspective as well. So Tom's already alluded to the fact that in terms of all types of additional needs, a diagnosis actually isn't required to access specialist provision. We've always been quite clear about that. It relates more specifically to autism, I think, because that's often the one where we have those conversations. But it's very much more around presenting need and then trying to match that presenting need to the appropriate provision. So in terms of FASD, there is obviously no discrete provision for children with FASD, but I know that we would find children with presenting needs from that in all of our specialist provisions and in our mainstream schools as well, because I think it's quite, the thing I do need to emphasise is that our starting point always is to try and meet need in as local provision as we possibly can, to try and ensure that as many children as possible can stay within their own community and get the benefits and the support that brings. So we are doing an awful lot of work with mainstream schools to build the capacity alongside trying to develop that specialist provision. But as I said, as Tom said, it would be around presenting need.
Thank you. Questions from the panel? Yes. Sure.
One further thing as well, which about the CAMS thing. Sorry about that, but as far as I'm aware, FASD isn't in the DSM-5, is it, as a diagnostic? It is. Is it in the new one? So that may well help the CAMS diagnosis and then picking that up as an issue, because if it's in the diagnostic manual, then it's within guidelines to diagnose.
Right, David, yeah.
Thank you. As a newcomer to this area of need, just a bit of clarification really. I find it a bit confusing that some of the reports refer to FAS, some of the reports refer to FASD, likewise with the stats. But interestingly, the report of the conference that took place, the title of that is Effects of Antenatal Exposure to Alcohol. So that's a kind of broader definition, which actually I find quite helpful. And I just wonder whether there is an intention to move to a more holistic approach to the problem as a whole, because there's a danger of, oh, hang on a minute, that's FAS, oh no, that's FASD, and the kind of attention gets a bit, lacking really. Thank you.
I think that's actually a real problem, because I think the terms are used interchangeably, and really, I suppose, I know there's moves towards looking at a completely different definition, like alcohol-related neurodevelopmental effects, which then covers everything. The way I look at it, I think of FAS as the far end of the spectrum of FASD. But I think you have professionals getting the titles mixed up. So never mind it being confusing for, you know, paediatricians sometimes I think don't know the difference and the words are used interchangeably. And certainly with our study we're being very clear that this is FAS because we don't want people, which is rare, going out there thinking FASD is rare. So whether we need a different term, which some people are advocates of, or whether we just need to be a bit more careful. But to me, FAS would be that, it would be under that umbrella of alcohol spectrum disorders, but at just one very extreme end. But certainly it is confusing, and we as professionals, I think, need to be a little bit more careful about the terminology we use to make it clear. So I certainly know a lot of the parents groups that, relating to FASD are quite concerned about our FAS study because they're worried that we're going to have a study that says FAS is this many cases in 1,000. And so every time I talk about our study, I'm very, very careful to say this is FAS, not FASD. But yeah, we need to take a bit more care about that.
Yeah, I think that would make a lot of sense in focusing on the spectrum, and FAS is, as you say, one end of that spectrum, but to look at it as a whole. Thanks.
Can I just say it's a bit more complex than just say it's not like ASD, because in the FAS group, some of these children, you're not just looking at the severity of their neurodevelopmental problems. Some of these children have very serious medical problems like heart defects. So it's a bit more complicated than say ASD, where you're looking at, you know, Asperger's at one end and the child with severe learning. You've got some children who are actually completely normal developmentally, but have very severe medical problems. And then at the other end, you can have children who look physically absolutely fine, but you know, and actually have normal intelligence, but have profound social and so it's an even broader spectrum. There was a convention, I mean, there's been numerous conventions looking at the terminology, and FASD was felt to be the best, the best umbrella term, but then using subgroups within that, like your alcohol-related neurodevelopmental problems. So it is complicated, even for those of us who...
Could we return to questions from the panel? Thanks. Thank you. Peter.
Thank you. Can we thank you for the paperwork as well, Jeff? It was very illuminating, and I think we've probably got a reasonable handle on it, given that we're all fairly dim. And while we're on terminological exactitude, and while we're juggling with FAS and FASD, where does all this sit with all the other substance abusing ladies? Those with opiates, how do we know that a lot of these are not polyaddicts? You know, where does it sit? I mean, and looking at the problem as a whole, substance-dependent mums, how much have we underestimated the incidence?
It's a very good point. There was a study in Glasgow, which I think, having looked at their group of substance misusing and alcohol, is quite similar to West Yorkshire. They found that in the substance misusing group, sort of opiates, etc., 50% of the women were taking high levels of alcohol. So there's a lot of comorbidities there. And there is a disappointing lack of interest, I don't know if that's the right word, in the alcohol use in pregnancy. There's a new charity called Alcohol Concern, which is an amalgamation of two of the big alcohol charities, and there's not one mention in their entire new shiny bump and case reports and about alcohol use in pregnancies. There's a lot about alcohol users who then parent and the effects of that, but there's very little about alcohol use in pregnancy subsequently leading to FASD. It seems to have just not be in the forefront of people's minds. So education is a massive, massive issue. But it comes back to, we can't even agree on terminology, and the terminology is confusing. So how can we educate if we don't? You know, it's such a minefield of complexity. Yeah, and then you add in the complex women who are also substance misusing, and it gets even more complex.
I think it's also important to say that...
Sorry, we've got a queue of speakers. Thank you. Fazila.
Thank you. In regards to, it's all confusing in terms of FAS and FASD. The diagnostic pathways that you discussed, and then obviously with Scotland possibly adapting a pathway soon. My worry is in the meantime, obviously, we've got children that are perhaps, like Mr. and Mrs. Fox, they're being slipped through the system, and like, you know, obviously they feel that they've not had the support. And in the beginning of their deputation, and they mentioned that they've come across like 60 or 70 other people, with not just in Kirklees, but in a wider Yorkshire region. How close are we to kind of getting some more information about getting our diagnostic pathway adopted for Kirklees itself, or Yorkshire and kind of the region? And I know it's something that you've already kind of, but it's a worry because obviously I'm thinking about these are parents that have already lost out, but then we've got parents that are obviously in the system or who are pregnant now and who are not having that support and don't know what's going to happen, so they'll be in the same situation as them. And it's just like a rolling effect kind of thing. So just trying to find out where that is, and that's the first part of my question.
Yeah, I mean, I think it'd be fair to say that we're not very close to a diagnostic pathway locally. I think because, as you've alluded to, that there isn't an agreed definition. I think what this highlights and what the deputations from Mr and Mrs Fox highlight is, first of all, I mean, there's probably three things we need to do. One is understand the scale of the problem locally, and that's going to be a challenge based on data. We need to understand what that means for children in Kirklees. Two, we need to think about awareness raising and checking out with the key professionals like CAMS, paediatricians, what their awareness is of signs and symptoms and what can be offered. And then three, I think we'd need that agreed diagnostic pathway. But my experience of dealing with contentious issues like this in the past, so for example with autism, there's a condition that was termed pathological demand avoidance disorder, which is actually a subsection of demand avoidant behaviour, and that's taken years and years and years to actually have an agreed definition in the DSM, you know, and actually for that to be in practice. So I think it's really important that following the deputations and what we all know, we try and look at what we know and what we can do in the absence of that diagnostic pathway. And obviously when there's an agreed one that comes through, I don't know if you want to pick that.
Yeah. I mean, that's all absolutely true. I mean, I approached Scotland and I said, look, you've done this, you've based it on Canada and based it on Australia. They would be happy with acknowledgement for us to use their pathway. So I don't think we have to rewrite the pathway. I think we have to get buy-in and agreement that it's okay to use that pathway and whatever additional resource we need for that pathway. So I don't think we have to write it. I think we can base it very much on consensus from across the world, and now from Scotland it would just be getting agreement and getting buy-in and the actual whatever additional resource would be needed, and space and time and all those things, rather than agreeing what we're going to call FASD.
Do you want to come back, Fazila?
And if that is something that we could just generally use, will that help moms and Mrs. Fox to kind of enrollment to make sure that they've got the right support that they need?
It's not necessarily training diagnostics. It's about giving that prevention message out, and that prevention message is pretty clear, and it's zero alcohol during pregnancy.
So the antenatal packages that we give out, do we have specific documentations or specific leaflets that go onto FASD, or the consequences of FASD, or something in terms of that? I know that there's a whole big point to get some into, but...
Yeah, locally I think there is some information from the information that I got back, but I will check on that, because again, I think some of that may be verbal And, you know, the other thing that women will say as well is that they get given loads of information, you know, at that time. So it'd be worth, I will double check with the providers what they actually give out. Yeah.
Alison.
Hello, I'm Alison Munro. I'd just like to ask you a question. From having read the information that we've been given this morning and listened to you, it's very clear that awareness is key. And I mean, you know, lots of people, you know, don't like to admit how much they drink, so it's got to be handled very carefully as well. However, my question really is around the education aspect, because if there are going to be a lot more children coming through with the diagnosis, how are schools going to cope with that, with those additional needs? Because I know it's very difficult to actually get a statement in an ECHP and get additional funding. So I'm just wondering, in relation to the school aspect and the educational aspect, how is that going to be dealt with if you have a lot more children coming through with a diagnosis? Thank you.
We are already noticing the increase in complexity of needs of children coming through school, not just for this, but for lots of other types of special educational needs as well. And we are responding to that because obviously we're seeing both a growth in the number of children who are coming through schools with special educational needs and in the complexity of those needs. And it is a very interesting picture. Our data is telling us that the complexity of need is a fairly recent thing, actually. And if we look at the data of children coming through, you can see those more complex younger children who are now making their way through into secondary school. And there may be a whole host of reasons for that, but we're looking at what we do about it now that we're in this situation. So when you then put into the sort of into that context, the kinds of needs that many of these children have around a sort of a combination of presenting behaviours, needs that schools may need to address. We have begun something called the High Needs Review because we are very aware that the ask of schools has increased considerably over the last few years, and at a time when perhaps funding is a little less available than it was. And so the High Needs Review, we've developed an enormous workforce. We are developing an enormous workforce development strategy for all of our schools in partnership with our schools to try and ensure that staff feel confident and able to deal with the very great range of needs that they are now encountering. And I think one of the reasons I've come today, because obviously the focus is more on the health aspect of this, but I needed to come and listen to what you were all saying. Because, as I said, Tom and I work very closely together and we need to make those connections. So FASD is not a category in its own right, if you like, within the Code of Practice, but obviously it is the combination of needs. There are four main areas of need in the Code of Practice: sensory and medical, physical, communication, interaction, cognition and learning. And you could argue that FASD could go across any and several of those. So, interestingly, what you're listening to, I'm going to be speaking to Tom after this meeting to go back to the High Needs Review Workforce Development Group to say what do we need to include about this specifically within the work that we're doing with our schools. In addition to that, so that's to do with workforce development and their capacity to deal with it, which is an enormous part of this, actually, because schools have to feel confident that they know that they are meeting a child's needs. You talked about getting an EHC plan. Interestingly, the numbers of children within EHC plan have gone up by about 25% in Kirklees in the last 4 years. So whilst we hear differing things, yes, we hear from parents and many people that they are difficult to get, but yet we are seeing a huge increase in the numbers of children who have one. That is not the answer on its own. You can have an EHC plan, and then what? We are looking at revision of all of our funding around EHC plans, and the government is looking at its funding to do with SEND in general, because there is a general recognition that perhaps it isn't sufficient, and you only have to look at what's being published in the national media at the moment to see. There's an awful lot of information in the media about it currently. We are certainly, though, looking at our EHC plan funding with a view to ensuring that the guidance that goes out to schools around each area of need and our expectations of schools in meeting that need as it becomes more complex, that the funding that is attached to that need enables them to do what we want them to do. So we are going to be seeing an increase in funding that's going into schools for children with an EHC plan at the moment. We're waiting for the DFE to tell us what they're going to be doing about SEND funding as a whole, because there's quite a lot of discussion about it down at the DFE currently.
Thank you for that. I mean, I can see that by children being diagnosed, it helps teachers understand that child maybe it's just the funding and dealing with these children and the problems that they're presenting at schools. I can see it's going to be an increasing problem. Yeah, thank you.
I'd like to ask a question, if I may. Leaving aside the problem of prevention, which is obviously a huge thing to leave aside since it's palpably preventable, what do you think is the advantage of identifying a child's learning difficulties as being the result of alcohol as opposed to anything else?
I mean, what I've learned from the parent groups is that there's a specific way of managing perhaps the learning need or the behavioural need of a child with FASD that works for them and the way their brain works, as opposed to a different child with those same needs. So understanding it and getting the diagnosis, and then maybe going into schools and say, children with FASD in this scenario will behave like this and respond to this. I don't know if you would, that's what I've learned. So actually having the diagnosis and knowing it and knowing how those children respond means you can tailor your management of it to their specific needs.
Thanks. I mean, it's a huge long list of behavioural characteristics that might result from FASD, which, I mean, looking at it, I think might also result from a parent who was addicted to social media rather than speaking to their small baby. You know, I'm not sure that are you saying that you can definitely pinpoint FASD as a distinct learning difficulty outside others?
I work with a clinical psychologist who has a special interest in FASD. And there are adaptations to standard cognitive tests which really are very helpful in picking up children with FASD. There are patterns of, you know, whilst each child is different, they often have a very spiky profile with very specific areas of difficulty. So actually you can hone in you know, that it's not, I mean, we've maybe presented a very broad, nebulous picture, but actually there are, you know, and I'm sure the Scottish system will refer to this, because some of the others do. So there are specifics you can look for. And my experience with teachers is that if you educate teachers about FASD, they are fantastic. You know, they will often pick up the children in their classes who've got it, and they will often devise their own pathways of, you know, with the sort of high-level teaching assistants. They will get to know those children and will work very well with them. So there's optimism there, and as I say, you can be. It's not quite as nebulous as it may be, as it may be seen.
I think, sorry, Chair, but I just think as well that's what I think what you're alluding to is that a lot of the behaviours and symptoms have got a lot of crossover with other certain aspects, certainly ADHD and ASD, and I think that's what makes it more complex. I'd be interested to see maybe two things: the difference between how you deal with a child with ASD, how that's different to how a child with ADHD or ASD would be dealt with, and I'd like to understand that as a commissioner, because I'm not sure.
Did you want to say something?
Yes, Catherine. That's very important, which is how parents manage their children. I think the way that parents are able to manage their children with FASD compared to a child that doesn't have FASD is very, very different. We have two children one with FASD and one that doesn't have FASD. Our other child has attachment disorder. They both require very, very different parenting strategies. They need the parenting strategies are completely different. We've only come to understand that through a lot of trial and error, years of practice and training, and I think parental support to be able to do that is incredibly important, because it is exhausting parenting a child with additional needs. I've changed my job in order to be able to parent our child. I can't underestimate how important what you've said there, how important it is. I'd also like to respond to a point that was made earlier about alcohol and other substance misuse, which is that we cannot assume that all mothers who drink during pregnancy also misuse other substances, and that all children that are born with FAS or FASD are also children that are born as a result of substance misuse and are removed or looked after children. This is also a middle class problem, and we must understand that as a scrutiny panel, that there are birth mothers, and they mustn't be tainted, they mustn't be looked at any differently than adoptive parents as well, because drinking at any stage in pregnancy, it can be a couple of glasses at one stage in pregnancy, or it could be somebody who has a problem or somebody who goes out. It's education for all of those mothers at any stage.
Thanks very much. Peter.
So I know Emily's not here, but I just wanted to clarify on the preventive side. Is this damage done so early, for instance in the first trimester, for example, is it done so early that nothing can really be done by midwives and the antenatal service? I see that the midwives administer something called a severity of alcohol dependence questionnaire, which with real alcoholics it'll just draw lies. And I wondered if there's enough effort being put in. I mean, we're talking about the horse having bolted for most of this morning, and I just wondered if there is more to be done along the lines that Councillor Lunat mentioned as well, with more information for expectant mums.
Yeah, I mean, I'll take some of the key points from today back and discuss with Emily. But the NHS recently changed its guidance to say that there's the only safe amount of alcohol in pregnancy is none. I mean, I would make the presumption, and it would be a presumption, that if you were a relatively heavy drinker and you found out you were pregnant, maybe, 2 months in or a month in, that actually if you have an intervention that makes you stop using alcohol or reduce it, that's only going to have a positive impact on the pregnancy. I've no empirical evidence to back that up, but that's what I would presume. So I wouldn't say that. I think if a midwife was here, what they would be saying is that's why they look at the healthy behaviours when the first visit's booked in, to say, you need to stop doing X, Y and Z if you are doing that. I think the severity of alcohol dependence questionnaire is probably more focused on your really heavy dependent drinkers and looking at kind of how that can be reduced and managed within pregnancy. But I think there's a real issue about education, and there's a real issue not just about education but about choice. So we always make the assumption that if you tell people something's the right thing to do, they'll do it. In Kirklees we still have a high rate of women smoking when they're giving birth. So there's something about how we deliver that message, not just the message itself.
Yeah, just to follow up, please. Is there anything you can pick up on the 20-week scan that's of any prognostic significance?
In a child who had been severely affected by alcohol use in pregnancy, you might pick up abnormalities on the structural abnormalities, a heart defect, a specific defect in the structure of the brain. you wouldn't be able to reverse that, but you might pick that up. But I would second Tom's point that there may have been damage done if you've drunk in pregnancy before you know, but you will minimise that damage by giving the good advice. And I know there's also a real move to be going into schools, to be targeting 17 and 18-year-old girls and telling them about this, so that actually their preconception drinking behaviour is modified. But I think to do that, you've got to get into sort of, 16, 17, 18-year-old girls. And there is I think, from what I've understood from midwives that have tried to do that, there is a little bit of reluctance for midwives and healthcare professionals to go into school and talk to 17-year-old girls about drinking and being pregnant. I think that needs a bit of a change, but there certainly is a move to try and get in there really early with this message to stop even that drinking before you know you're pregnant.
Yeah, one last thing from Mr. Fox, yeah?
It's a very good point. Next time you go into a doctor's surgery, have a look at the posters on the wall and see if you see a single poster about drinking in pregnancy, because you won't. Health centres, doctor surgeries, there aren't any posters.
David.
Thanks. I found Mr and Mrs Fox's report very good, very concise, and easy to get through. The solutions at the end of the report look particularly relevant, and just wonder whether those solutions could form a bit of a sort of framework for looking at this issue further jointly. And one specific point, the first one, which is about having perhaps a regional protocol and strategy. In your report, Tom, you do mention what's happening at the level of West Yorkshire and Harrogate, with a work stream which is starting this month, I think. It seems possibly that might deliver the first point on that solution, but we welcome your comments.
Yeah, no, I completely agree with you. I think, in terms of the report, I think what we need to do is look at the recommendations, first of all, obviously, of scrutiny today. Also, the recommendations from the report take those back to the CCG, but you're right, some things are done now on a West Yorkshire-wide level, and the kind of maternity commissioning framework is also done on a West Yorkshire-wide level, so I'd be quite happy. Maybe it'd be something we might do jointly in terms of taking that forward to use that network.
I'd just like to sum up then on the recommendations that I think the panel are making. One is that we're going to check what alcohol advice is given antenatally. Secondly, that there should be a nominated paediatrician with responsible for FASD to liaise with Catherine. And also where else could advice about alcohol in and immediately prior to pregnancy be disseminated? Is there anything else people would like to add to that? David?
Yes, just if perhaps there could be a focus on the five solutions that are put forward in Mr and Mrs Fox's report as a kind of framework really for looking at these issues.
Zila, yeah.
Just echoing on that, just making sure that we include a training package for staff to make sure that this, even though without the diagnostic, but at least recognition of such a illness is available there or can be picked up on.
So can I just check, do the panel agree that all five solutions proposed by Mr and Mrs Fox should go forward to the Health and Wellbeing Board? Yeah? Okay. Fazila.
Once it's been to the board, then you can just come back and just let us know what's happening. Is that okay?
Yeah, we want advice about. We want to know what the alcohol advice is and where else advice about alcohol could be disseminated as well, don't we? Yeah, thanks. Is there anything finally and very briefly you'd like to say about this?
I'd just like to say thanks very much, because emotional.
Thank you.
It's taken a long time to get to this. Thank you.
Catherine and Tom, is there anything more you want to say now? Or,
I don't think so. One very last thing I wanted to pick up on, just as a reassurance really to commissioners and things, is what we're talking about without belittling what you do and what the interventions when we get this diagnosis, the specific parenting and the specific educational approach, they're not necessarily that expensive. We're talking about a way to tailor how you educate in skills and a way to tailor how you parent, which they'll have a massive effect, but we're not talking about expensive anti-inflammatory drugs or something that's going to cost a lot. It needs to be very specific and very focused, but I don't think it's an expensive intervention which has the potential to make a massive impact educationally and for the lives of these kids.
Just for me, just thanks to the panel and thanks to Mr. and Mrs. Fox. We're just having a quick discussion that as part of the work moving forward, it would be quite useful to work with Mr. and Mrs. Fox in terms of developing some of those aspects. So we'll make sure that we keep in touch and do that.
I think you're due to meet outside now anyway, aren't you? So, there we are. Thanks very much. So the only other task I think for today is to have a look at our work programme. Did the panel want to raise any issues with the work programme at all?
Is the ambulatory care unit in Dewsbury still closed, do we know?
The answer is yes, it is still closed, but I can confirm that as per the agenda plan that's been issued, we will be getting an update from the CCGs and also from the Trust at the next meeting. So they'll be able to give us an indication in terms of what the timescales will be for any potential provision at Dewsbury going forward.
Okay, so date of the next meeting is the 12th of February. Thanks very much for coming today. Thanks.